The next speaker is from SMU again. It's a person that opened the meeting for us, and that's Prof. Shingai Mutambirwa. He has been introduced. So you know, Shingai is a friend of the nuclear physicians, and he's one of the urologists that actually looks at the patient from the beginning to the end. He's pretty much involved in the genetic analysis of prostate cancer, involved in the clinical management, robotics, and of course in the imaging, and of course promoting targeted radionuclide therapies. As you know, we are doing guidelines with him and collaborative with the oncologist, and there are renewed guidelines that we will do, and he is really published in very, very high impact journals, despite of course having various hobbies. Thank you.
Don't mention my hobbies. Colleagues, thank you so much for accommodating me as a urologist in this auspicious occasion. And I'd like to thank also the organizing committee, particularly for putting my talk at the last talk of the dying session. And I think it's appropriate because essentially I'm a Neanderthal as a urologist, as a surgeon. You guys, after Thomas's, Erica and Nozipo's high-flying discussions, I'm a Neanderthal. But the good thing is that paleontologists say that Neanderthals, Homo sapiens and Homo erectus, they all actually lived at the same time in some areas. So I'm hoping that I'm going to just talk a little bit about some vignettes about what I think we are doing as urologists, where we fit in with nuclear medicine, and then at the end maybe just talk about what might be in the future. There we go. All right, these are my disclosures. Some are relevant. First of all, PSA. We've been testing PSA to try to find out about prostate cancer. Remember, PSA is actually a kallikrein-like enzyme which is found normally in prostate tissue. It liquefies semen. After a guy ejaculates, about 20 minutes later, it becomes liquid. That's what it's doing. So the reality is it's normally produced there. And the reality is that the reason why we use it is not because it increased in cancers, but because if you were to stain histologically benign prostates with prostate cancer, the benign will have less PSA than the cancer. Because what we're looking really is at the ducts and the glands. And once the glands get blocked up by messing around cancers, it's released into the bloodstream, and that's why we get a rise in the PSA. Had a bad image for a long period of time. We know that the recommendations initially said we should stop doing PSA testing by USPSTF. That's all changed. And mainly because the reality is that prostate cancer, that PSA has actually decreased the risk of us dying from prostate cancer as men. It wasn't radical prostatectomies, which I've been talking to a lot of our colleagues that we were at ASCO. They were saying 10 years ago that urologists will only be doing circumcisions in about 10 years because none of you guys will be targeting our prostate cancers without us having to cut. And the reality is that radical prostatectomy didn't decrease the risk. It was mainly PSA testing early. And so in our country particularly, because we are actually at high risk because of mainly black Africans. We know that black Africans are more likely to get prostate cancer and they're more likely to die from it. So our guidelines currently say that we should be doing PSA testing from the age of 40 in all men in South Africa. We've also improved a little bit. Erica talked about MRI. We used to do what some people would call fecal biopsies, where we go through the rectum and just jab the prostate to find a look for it. We weren't targeting. In a breast cancer, you're not going to be good going and just jabbing a needle everywhere. Erica was scared of one needle. We stick many, many needles into our prostates. And the reality is that's not appropriate. We're only targeting about 1% of the gland. Pickup was not very good. We were picking up the Mickey Mouse cancers, which are Gleason 3+3 or ISUP1s, which shouldn't really be treated. And but now with MRI as part of our guidelines, we're slowly moving out of our doldrums as Neanderthals. We're also improving a little bit when it comes to other imaging. Again, Erica mentioned about how MRI is operator dependent. It's very expensive. It takes a lot of time. It can't be done in patients who have prostheses and things like that. At the end of the day, I think the future, we're involved with Larry Klotz from Toronto, on these things. We're using high-frequency ultrasounds, which seem to have the same outcomes as MRI. The frequencies are somewhere in the region of 30 hertz instead of the normal ones, which are between 5 and 12. And outcomes seem to be better. It's going to also work out cheaper, and we've done a cost analysis in Africa where it works up so much cheaper that we might be able to pick up in a better way our management of patients. Again, the fecal biopsy, sticking a probe up in the anus with a condom on it, and then we target the thing, get a bit of infections here. Targeting wasn't very good, and we can't get to the front part of the gland, which about 25% of black Africans have their cancers in the anterior part of the prostate. We're now going towards perineal biopsies, which should be the future for us as well. But even when we do this, we have to make some better patient selections. And the main thing is that we're trying to incorporate things like favorable intermediate, unfavorable intermediates. We're a bit indecisive when it comes to urologists. But when we're looking at some of the aspects, like for example, a low volume disease, low PSA density, in other words, if you've got a big cancer, a big prostate, and a raised PSA, it's less likely to have a prostate cancer than a small prostate with the same level of PSA. The PSA density is a big thing, and we can actually incorporate that. Multiparametric MRI is also there, but molecular imaging, which is in your area, is so important as well, although you might argue that MRI is also molecular imaging. One of these, I know you've seen many of these things. Mine is probably one of the most ugly PSMA PETs, but the point is that we can pick it up earlier, and there are lots of trials ongoing, as you know, that are actually using it upfront on patients to actually make decisions on whether we even have to do a biopsy. The reality, even when you look at the APCCC, the Advanced Prostate Cancer Consensus Congress, which is really a great conference if you really want to get going there. It's usually in Lugano in Switzerland. The majority of patients now would, especially independent of risk or with localized high risk, are going to be asking for PSMA PET scans if the patient needs to get investigated. How do we treat our patients? Again, bit of hit and miss, active surveillance, focal therapy, which is the future, and it's also going to be big for you because we're going to need specific imaging to actually pick up where we should be doing the focal therapy, and whole gland treatments. All of these require a trifecta. That's oncological control, that's making sure that the patients don't wet themselves, urinary incontinence, and erections. Erections is part of it. We're really big on erections. It's one of the trifecta for prostate cancer therapy. And there are lots of guidelines. The important thing for us to remember is that the majority of patients who have prostate cancers are not going to die from it. If you have a life expectancy less than 10 years, we do not want to be doing anything for you. We do watching, waiting. Protect T, 15 years on, they stratified patients to either doing radical surgery, radical prostatectomy, external beam, or watchful waiting. The outcomes at 15 years were essentially similar. The reason, of course, there are some caveats to this, for example, that most of the patients were actually low risk, and we know we shouldn't be treating low risk patients. So high risk patients still need it, and that's where your imaging will help us to make a decision whether we just do watchful waiting or we watch a patient longer. We have improved ourselves as well. We used to just cut out every prostate cancer that came out. That's one of the reasons why we had such a bad recommendation from the USPSTF. Nowadays, at least 50% of our patients should be put on active surveillance. Unfortunately, worldwide, it's not picking up as much as we should. In Northern Europe, Sweden, and that sort of thing, I do have up to 80% of their patients on active surveillance. South Africa, we're improving as well. One of the issues that we have, which we can't discuss today, is the fee for service, because it's actually more lucrative to do radical therapy. But the point is that the trifecta of oncological control for patients adequately diagnosed for be put on active surveillance is exactly the same as radical prostatectomy and external beam. The incontinence rates for active surveillance are essentially zero. The incontinence rates for radical prostatectomy in the best hands is probably around 20%, except for me, of course, because none of my radical prostatectomies have incontinence, and never happens to me. And erectile dysfunction, you're looking at about anywhere, again, about 20% of patients. So it's not feasible, it's not good for our patients to treat everybody with radical therapy. You're going to have arguments. There are brachytherapists, there's radical prostatectomists in South Africa, and when they come to you, you'll be usually well down the line, so you won't realize it. But there's a big fight about it. It's again about compensation and stuff, but the reality is that we'll never have a randomized control trial comparing radical prostatectomy to surgery. For our purposes, it's exactly the same. Outcomes as far as oncology goes. Side effect profile, slightly different. Focal therapy, this is where you're going to come in, because we've been battling to get to the point where we can actually just target the one area where the cancers are, or the two areas or three cancers. We haven't made enough impact on this. We know MRI is leading us down this path, and this is probably the golden rule for us in the future, that when we have a patient with a little bit of nasty-ish cancer there, we want to focal up the area, because the outcomes for the trifecta are equal to active surveillance, but we don't have the data for that, and that's where nuclear imaging, I think, is going to play a huge part. Regardless of what we do on all of these things, about 30% of our patients are eventually going to metastasize. It's worldwide, no matter what we do. And unfortunately, they then need to get further therapies. Again, I was chastised by the two Michaels, Mike Hoffman and Mike Satechi yesterday, about talking about radiation oncologists and where they fit into your nuclear medicine therapies. But I do have to mention that they have done some good work. For example, if we have high-risk patients, we used to just traditionally just give salvage, adjuvant radiotherapy, which also increased the side effect profile of our patients. We now know that the data shows that we can do salvage, and saving about 40 to 50% of patients with high-risk radical prostatectomies from getting radiation, decreasing side effects, decreasing cost. Also, we know that oligometastatic disease is different from polymetastatic disease. And we've been using this Mickey Mouse imaging, I mustn't call it Mickey Mouse, though, but bone scan, CAT scans by themselves. We're not picking up enough of cancers. We know that even when it comes to STOMP and ORIOL, which showed better outcomes for patients who had oligometastatic disease on standard or old school imaging, if you targeted the cancer as well as the oligometastatic disease. But subgroups of these studies also showed that if they had PSMA scans and you targeted the PSMA positive areas, the outcomes were even better. So I think the future is for oligometastatic disease is going to be targeted therapies. But then we go forward, we have so many different drugs that we're using. All of them are very effective in many ways. The big problem for them is that, first of all, we need to augment a lot of these standard androgen deprivation, and I talked about testosterone this morning. I think, like one of my colleagues, oncology colleagues, says that ADT is probably worse than chemotherapy long run for a lot of patients, because chemotherapy at least stops, ADT keeps going and giving problems. But we need to remember that it's still the backbone of treatments for the majority of our metastatic patients, and we have to add one of the modern what we call RPs, androgen receptor targeted agents or pathway inhibitors. These are the enzolutamides, the darolutamides, the abiraterons. Because if you look at when we just do standard ADT, almost the majority will be castrate resistant within 2 to 3 years. If we give an RP to the patients, we double that 6 years before they become castrate resistant. It's huge. There's no solid tumor which is done so well with any medications. The problem, though, is, that first of all, a lot of us as urologists don't want to incorporate it. We again, being Neanderthal, we're sticking to old school. We're saying that it's not appropriate. We're not looking at the data. We need to look at the data. But the problem also is cost. We know that a lot of these drugs are so expensive. For example, abiraterone, you're looking at about anywhere, but it's a bit less now because it's genericized, but it could be anywhere up to $3,000 per month, depending on when it first came out. Huge amounts of money, but the point is that outcomes for our patients are so much better. And going forward, I think we must remember that we need to look to the future as well, even amongst nuclear medicine, even though you are the future, and that's for genetics. When you consider the way we risk stratify our patients, from NCCN or CAPRA, it's not much better than a coin flip. But when we incorporate clinical genomics, we're almost reaching the point, the golden chalice, where we can actually make a correct decision on how we're going to treat our patients. Lots of things out there. There's all of these things. There are different platforms where you can get the genetics, be it germline or somatic. The problem, again, is cost. Some of them are up to $5,000 just for the test, but it's going to impact our therapies, including for you as nuclear physicians. And when we incorporate nuclear physics, radiology, histology, and the genotype, it even works out better for us. And at the end of the day, I think this is going to be the way we should be going. Again, cost is probably the issue, because it's also going to impact on how we treat our patients. When you consider, for example, if you have an MSI high, pembrolizumab has about a 50% response rate, and but only about 5% of patients have it. And pembrolizumab is approved across every tumor if they have MSI high. Similarly, PARP inhibitors for DNA damage repair, 33% responses. There's huge things that we can go on when we do this thing, provided we do get the genetics. And that brings us to the fact that we have to be more multidisciplinary. Nuclear physics, nuclear medicine is now an integral part of every part of prostate cancer management. And I think we need to remember that we include people who are going to lose their jobs, for example, to AI. That would be the pathologists and the radiologists. Sorry, I'm just joking. But we have to incorporate them quickly so that they can get some money. No, but the point is we need to involve everybody, because if we don't have multidisciplinary teams, we're going to have a problem, and the outcomes for our patients are poorer. The theranostic way, we know this is probably the target for the future. Again, my pictures are relatively boring, although I've taken them from some colleagues. And remember that also you guys, I'm so impressed that you're actually looking forward as well, targeting neuroendocrine tumors with different tracers rather than PSMA to make our lives better and our ability to pick up cancers and to treat them better. And of course, the rest of us have also stolen from you, using PSA to get BiTEs, which are targeting T cells to bispecific T cell engagers, to actually do something similar to what your radiopharmaceuticals are doing for our patients as well. Also, outcomes are looking good, but again, we need to integrate the different aspects of our therapies. This slide basically just showing that you can see that you're involved in almost every aspect of our pathway for prostate cancer now. There's no way you cannot be included from the beginning of any MDT. We need to keep you on board, and we're really grateful for, well, at least I'm grateful. Some of them might not be too grateful, but I think most urologists are very grateful for what you're doing. And this is stolen from Ken Herman's, one of his things. I think we have to now look forward to not only just having an additive effect of the different therapies, but synergism. And I think that's the way to look for. You guys are talking about dosimetries, about whether you should be giving with androgen deprivation, or if it's been on androgen deprivation for 6 weeks or whatever. These are the things that we need to do to get better synergy. But at the end of the day, remember, the patient's the most important. It's decision-making. We have to talk to our patients no matter what therapies we're doing, because we can't be paternalistic at all with our patients. But also remember to remind them on basic principles. Even if they come into your clinics and you're doing your scans, remember that they need to do the basics, exercise, make sure that they're not smoking, limit alcohol, which I try to do, but I obviously don't do it very well. But I haven't got prostate cancer yet, so I'm fine. But the point is, remember to go back to the basic principles. Don't just be talking about highfalutin things that we're doing. Talk to them about what they want, how they can make their changes. Do pre-habilitation for our patients. Before we even start them on therapies, whether it be surgical or your theranostics, let's try to optimize our patients. Make sure that they're in fine fettle for us to do this, to make sure that they have better outcomes. Because quality of life is the most important aspect for our therapies for our patients. And I think one of the things that we've learned from our involvement as urologists with nuclear medicine, and I must say thanks to Mike, who's one of my mentor, died from prostate cancer, it's well known, castrate-resistant. Mike did some treatments which extended his life significantly. Quality of life during that period is so important. We need to remember that that's the way it should go. So, when I started, and I'm older than Mike, so don't worry, I'm a bit over 80 as well, things were pretty simple. We'd just do local therapy, we'd give androgen deprivation, and then the patients would die. It's changed. There's so many different aspects. There's so many things we have to look at, so many interactions. So that's why multidisciplinary teams are so important. It's much better for our patients, but much more confusing. And that's why we have to involve everybody in this. And my future for me is, I think that when it comes to prostate cancer, we're going to be looking at genetics, genomics, serum markers, molecular targets, selection pressure, induced responses like neuroendocrine, and we can get to the point where we have personalized medicine. And that will be the best option for our patients to make sure that they have a healthy decision on treatment and also healthy outcomes for their prostate cancers. Thank you very much.